I'm going to spend some time today on diagnosis, screening, as well as safe swaddling and its importance for development dysplasia of the hip. So I'm going to outline a little bit on the terminology and the spectrum of DDH we deal with. And then as talked about, then I'll spend some time on screening, diagnosis, and swaddling. This disorder is not always present at birth. And most of us know when we read about history of this condition, we used to call it CDH, congenital dislocation of the hip, and then it got changed to development dysplasia of the hip because this hip can be normal at birth and may dislocate over a period of time. And that's so true about the last part that I'm going to talk about, swaddling. If you incorrectly swaddle these babies, what is a normal hip can over a period of time dislocate. So it's important to keep that distinction in mind. That's why now we refer to this as DDH. Depending on the severity of the spectrum, you could have anything from 2 to 3 per thousand live births to about 30 to 50 per thousand live births. It's quite a spectrum of what you may call as a DDH. And that's important to keep in mind. So a lot of the differences when we look at geographic variations and people talking about how the prevalence or incidence is so different between different countries, if you really dig deep into it, it's because people have not really specified what part of the spectrum it actually is. So we really need to understand, is it dislocatable or is it dislocated? If it's dislocated, is it reducible or reducible? Because all of that will have implication. Same way when we talk about bilateral DDH, is both sides just subluxable or dysplastic? Are both sides dislocated but irreducible, which is a completely different spectrum in terms of comparing treatments from one to another. So this is really, really important to keep in mind. So now when we talk about screening, and I'm going to combine a bit of screening and diagnosis together in this, screening can go from no screening, which is what happens in lots of parts of the world. You would hope that 100% of the children are clinically screened because it's something that can easily be done by anyone. And ultrasound screening, when we get to ultrasound, either universal, like in some parts of Europe, where every single child gets an ultrasound, or you can have a high-risk screening, which is what happens in most of the parts of the developed world, like in Canada or in the US, Australia, New Zealand. We don't do universal screening, but definitely do selective ultrasound screening on children that have risk factors. Clinical exam, it's very, very common, no matter where you're in the world. If you're screening for a child with DDH, depending on their age, you start off with Ortolani and Barlow test. And as the child gets older, then you start looking at other signs, or leg length difference, decreased abduction, Galeazzi sign. When children get to a walking age, then we start looking at lumbar lordosis and either one side Trendelenburg gait or bilateral, you have a waddling gait. So it's important to keep in mind, based on the age, your clinical exam may differ. So Ortolani and Barlow maneuvers, I'm not going to spend time with this audience describing what they are. You're all very familiar with that. That is a test that you can master if you examine children. And now coming to ultrasound, ultrasound is really popularized by Graf from Austria, and then subsequently adopted by many other people around the world. You can either do a static exam or you can do a dynamic exam. The most popular one is what's described by Graf, where you look at percentage femoral head coverage, you look at alpha angle, you look at beta angle, and then you see what the dysplasia metrics are. And again, I'm not going to spend a time actually describing what each one of these are. You can go from type 1 all the way up to type 4. Type 2 is again subdivided based on what degree of bony roof, bony angle, bony rim, and cartilage roof you're actually looking at. And what we deal with is type 2C or D, and 3 and 4, where are really issues that we often have to treat and pay attention to. The rest of them can be a mild dysplasia, often a lot of people watch. It's important to understand when do you actually do these ultrasounds, especially if you're looking at dysplasia, when is the right time to be looking and differentiating between apples and oranges? So this study done out of Adelaide, Australia by Jacques Riyad and Peter Cundy showed that a lot of these hips, if you actually screen them early, are immature. So you may think they're dysplastic and may start treating them. The best age to differentiate between dysplastic and really the ones that need to be treated versus normal are around 6 weeks of age. That's when the alpha beta angles are mature enough, femoral head coverage is mature enough that you're actually able to separate out between what is truly dysplasia versus normal development. So it's important to keep that in mind. If you're worried about dislocation, get an ultrasound anytime. If you're worried about just dysplasia because of family history, breech presentation, whatever, and the clinical exam looks normal and you're quite happy with it, then best to wait till 6 to 8 weeks of age. And it's important to also understand this paper where Woody Shankar looked at it, what are the different characteristics of clinically dislocated but reducible hips on ultrasound. And they found roughly when you get to a femoral head percentage coverage of less than roughly, say, 35 degrees, you start seeing that a majority of them are dislocated hips. Again, this is not set in stone. This is not done from large numbers, but gives you a rough guidance about where you start seeing the dislocated hips. If you see on ultrasound of less than 35% femoral head coverage, more likely chance this hip is dislocated. Here is an example of discrepancy sometimes you can find on ultrasound versus an X-ray. This, you would probably look at it and think this is a mild dysplasia, alpha angles measuring about 51 and 52 degrees, and the percentage femoral head coverage is measured somewhere between 45 to 50 degrees. You know this hip is dysplastic, but you're not thinking that it's that bad. 2 days later, when this child had an X-ray, you can see this X-ray looks a lot worse than on ultrasound. That's why we never discharge patients just purely based on ultrasound. We often follow them up, even when the ultrasound is normal. You follow them with an X-ray at an age where you normally do an X-ray. And now there are newer metrics that are coming out using three-dimensional ultrasound. And it's no surprise when you compare three-dimensional ultrasound to two-dimensional ultrasound, and especially looking at automatic acquisition of these, that you actually tend to reduce the variability that's described in the literature based on different measurements. So 3D ultrasound is being tested on experimental basis, including our own institution, and it's not mainstream yet, but certainly something to watch out for in years to come. Now, how do we interpret X-rays? When is the right age to start doing X-rays? Most of us start looking at X-rays somewhere between 4 to 6 months of age. And what's really important based on old classification systems that we used to use, like TONIS, is presence of this ospic nucleus. We do know it's quite variable when this ospic nucleus might appear. So again, this is TONIS classification that takes into grade 1, 2, 3, 4, based on where the ospic nucleus is. What do we do if the ospic nucleus is not there? So this classification system by IHDI takes into account that midpoint of the neck, which is called as H point. That is where you start looking at where that is compared to your Hilgenbriner and Perkins line. And then you start classifying them into grade 1, 2, 3, and 4. There is a study done out of Holland, really looking at comparing TONIS classification and ultrasound. We're actually doing the same study comparing the ultrasound versus a IHDI classification. So hopefully if we can show there is a reasonable amount of correlation, we can start probably bringing down the age at which we do X-rays. So in places where ultrasound is not available, we might be able to do X-rays. So again, here is a classification system based on using that. Again, I will not read too much into that. Again, going down on looking at ultrasound versus X-rays, here you have an ultrasound showing almost a normal looking ultrasound based on this. But if you look at an X-ray, that left hip is dysplastic. So it's really something to keep in mind as to when you do and how you look at these X-rays. Normally, we get these plain X-rays. You can actually, the way I do them is I turn the X-rays around, ultrasounds around like plain X-ray to try and get, some understanding for me to visualize and to compare with what I would look at a normal hip X-ray. Now, what kind of screening should be done? I'm not going to spend too much time. Al is leading one for, POSI and IAP and other partners. Very soon in India, we'll have India's own guidelines for how to screen and what risk factors we should pay attention to. But these 4 risk factors are important to keep in mind: breech, family history, history of clinical instability, and swaddling. And again, I'm not going to go into details about these different studies that are done to screen, not to screen, decision analysis. Really, the bottom line is all children should be clinically screened, and when in doubt or when risk factors are there, we should do selective ultrasound screening. Okay. Now, what do we do if 6-week ultrasound is kind of normal or there's mild dysplasia, right? This study done out of San Diego showed even though those breech babies had a normal ultrasound, roughly 30% of them ended up having abnormal X-rays. So their recommendation is definitely to follow up with another X-ray. What I do, swaddling is long been suspected as a key factor for dysplasia of the hip. And this is a correct swaddling, as you can see, with the hips abducted. Incorrect swaddling is wrapping this baby like a burrito. And you definitely want to avoid that. And this study done from India by none other than Al and Rujitha and Deepika showed very clearly very few people are aware of the correct way to swaddle our children, even though swaddling is not an uncommon practice in India. So it's really important that we raise the awareness about correct way to swaddle these children. So this is the conclusion from that paper. It seems to be a deep-rooted tradition, but people are not really being taught how to safely swaddle the hip. So if you ask me what is truly a preventable thing for hip dysplasia is really educating people about proper swaddling if those communities were to swaddle those babies. Thank you.